Anita mentioned most of it, but Dr. Sundar will be helping us with the IPF trials up at the university. And so he has been with the Intermountain, and he's just recently transferred over to the university so he can be more involved in the research end of pulmonary fibrosis. He has helped a lot of people with sleep issues in the past. And you spoke to us before once on sleep problems, sleep apnea. He's an adjunct professor at the university, and he's been the director of the pulmonary and critical care research at the IHC, the Urban South. And he did his fellowship in pulmonary medicine at the University of Utah. And he's been some investigator when we first started with the gamma interferon trial back in 1998 or something. Anyway, he's had lots of experience, and I'm just really appreciate that you were able to come today, and I know you'll offer a lot of good advice to the people, so thanks so much.
Thank you, Laurie, for that introduction. So just to give you a little bit more background about myself, I was in practice at Utah Valley Hospital and Pulmonary Clinic in Provo for almost 9 years, and during which time I held this adjunct appointment at the U, and it was a pleasure interacting with the IPF group, especially Dr. Sholin and Laurie and all of you, and I've been thankful for the support that the university folks at that time rendered in providing care for our IPF patients in Utah County. We were the only ILD clinic apart from the university clinic. So I moved up to the U in January of this year and took up a full-time appointment. And even though I'm doing a lot of sleep medicine, I'll be assisting with quite a bit of the care of pulmonary problems as well. We have a clinic that the university has started in South Jordan, which is in Daybreak, and we have at least 2 or 3 days of clinic there. I'm doing just 1 day right now, and it's our hope that we can help with the care of IPF patients there as well. So again, the goal of this talk is to talk about cough, which is often a very distressing and prominent symptom in patients with IPF. And as far as cough is concerned, it's a cardinal symptom of the disease, next to shortness of breath. And often patients with IPF come to light because of protracted cough. And having said that, the main cause of protracted cough that we see out in the community is not IPF. IPF is way down on the list of causes as far as protracted cough goes. We have a litany of other problems that come before IPF. But once patients have IPF, cough can be a pretty distressing symptom. And it's often the main symptom after dyspnea, or what we mean by dyspnea is shortness of breath. I'll show you some data that may be related to the severity of disease, especially it may be more prominent as the IPF gets more severe. And there's also some data coming out that it may have an independent effect on the outcome of IPF. More and more studies are coming up that are targeted solely at the treatment of cough in IPF, and that's an exciting thing that's happening in this field. So, just looking at the features of cough in IPF, there have been a lot of studies on IPF, but these 2 studies exclusively looked at the features of cough as occurs in patients with documented IPF. So first was a study out of San Francisco, which looked at 242 patients. And these are kind of the summary points from that study, that nearly 4/5 of the patients had a prominent complaint of cough. Interestingly, it tended to occur in patients who had never smoked more than patients who had smoked. And it also seemed to be more prominent in patients with more severe disease, as manifested by those that have drops in their oxygen levels when they exert, or that they have a lower value of what we call FVC. This is something that we routinely measure when we have you do the breathing test every few months. So it seems to be a marker of more severe disease. And on this study, it also seemed to affect disease progression, and that was independent of the severity of the underlying disease. So that was this big study out of San Francisco. The second was a study from UK, which again stressed upon the same feature, that it's a major symptom, it's a disabling symptom in patients with IPF. And it's similar to the degree of cough that's encountered in a condition called chronic cough, which often tends to be the commonest cause of cough that we see in our pulmonary patients. The cough in IPF usually is more worse than what is encountered in patients with asthma. So it is it is a prominent problem. The other thing they found was that when they objectively measured the cough intensity, so they used cough counters that are located over the throat, they found that it was much more prominent during the daytime, and it rarely kept patients awake at night. True, that may vary in some of our patients, but most of the times we hear that this is a problem that's present more during the daytime. Interestingly, in this study, although this was a much smaller study, which looked at the intensity of cough in a variety of ways, it did not seem to correlate with the severity of the disease. So before I go on to the therapies that we use for managing this cough, it's important to understand how the cough comes about. And one gentleman, Mr. Laurie here, already asked me the billion-dollar question, cough, is what is the receptor for cough? And we don't know the exact receptor or the molecule which triggers cough. But like pain, cough is a sensation that has developed over the years inside our body as a defense mechanism. So the primary function of cough is to expel noxious or irritant matter that goes into the lungs, usually through the trachea. Let me see if I can. They have pointed here. So once we go down behind the throat, you see that arrow, the blue arrow. That's where the vocal cords and the larynx is. So anytime anything enters that portion of the respiratory tract, it can potentially give rise to cough. But we have found that the receptors of cough exist in a wide variety of places besides the lungs. They exist in the nose, they exist in the sinuses, they exist in the back of the throat, and even down into the esophagus or the food pipe. And so the IPF cough is typically understood as coming from the lung. So when there is scarring in the lungs, there is distortion of the airways and the alveolus, the air sacs, and that leads to triggering of cough receptors within the lungs. But because of the fact that cough can be triggered from a variety of places, we look for other causes of cough, not just confined to the lungs, before we say that this is a purely IPF disease-related cough. And prominent amongst this is this complaint of reflux disease or gastroesophageal reflux disease, better known as acid reflux or heartburn. And we'll talk a bit more about that in the next few slides. The other prominent causes of cough arising from outside the lungs, which we like to exclude in a patient with IPF and cough, is that stemming from allergies. So if you have nasal allergies and what we term as a postnasal drip, this can lead to irritation of the cough receptors and also give rise to cough. True, this tends to be a less common problem in patients with IPF because of age or other factors. this can still be an issue, and this is easily treated with nasal decongestants or anything which helps reduce the buildup of these secretions. It's rare for us to see patients with asthma co-occurring with IPF, but some patients may have had a history of asthma in the remote past, and they may still have a state of what we call reactive airways, which can potentially trigger or perpetuate cough occurring from IPF. The other common cause of cough that we find in patients with IPF is that what occurs after viral bronchitis. So typically, many of us get a winter cold that, as typically is described, settles down into the chest, and usually, even though the cough becomes dry, it tends to linger on for a long time. We call this a post-bronchitic cough. And this can again be one of the common causes of cough occurring in IPF patients. And aside from this, we also look to see if there is concomitant heart problems, which can cause fluid buildup in the lungs and trigger cough. So coming to the issue of reflux disease, and I think many patients, or many of you may be on medications for this. And this is important because as patients have worsening lung disease, whether it be IPF or any other kind of lung disease, as the lung disease severity worsens, we tend to see more and more reflux. So typically in IPF patients, if we measure reflux using probes down into the esophagus, we see a very high preponderance of reflux in IPF patients. And reflux is, just to define it, is the movement of acid or stomach contents past the lower esophagus. So the big pouch is the stomach, and before that tube coming into the esophagus, there is a refluxing back of stomach contents into the esophagus. It's shown better in that picture on the right side. And this has again the potential to trigger cough by a variety of mechanisms. It can trigger cough receptors by stimulating the lower esophagus and lead to cough. Or more importantly, the reflux, the material that's reflux, can go up all the way back up into the esophagus and come down back into the lungs or irritate the vocal cords or the laryngeal structures and give rise to cough. So the typical symptoms of reflux, as we understand, is sort of a burning sensation in the middle of the chest that goes upward. But unfortunately, for most of the patients, we don't see these classic symptoms. Reflux tends to manifest in a very atypical manner in nearly 40 to 70% of the patients. In some patients, it may just be a sensation of a sore throat or a lump in the back of the throat when they get up in the morning, some scratchiness in the throat, some hoarseness of voice, and in others, it may be completely asymptomatic. So, because of the fact that this is such a common problem, we tend to treat this in the majority of IPF patients. And the standard therapies are what some of you may know as the first line is usually what we call histamine receptor antagonists. So these block acid secretion, and the prototypical medications are Pepsid or Zantac that you get over the counter. Did you have a question, sir? So the second group of medications is what we call proton pump inhibitors. And again, the typical medications in this are Prilosec or omeprazole or Prevacid or Nexium or Protonix. These are the ones we use for most part as standard of care in patients with and without IPF when we want to treat reflux disease. And the third thing is lifestyle changes, eating smaller meals during dinner time, and then avoiding foods like chocolate, mint, spicy food, fatty food, everything that makes food tasty in the American diet. Also helps in improving the reflux. So